Is this yours?
Yes. This is embarrassing. Who still uses this?
May I have my pen, please? What was it? Okay, we are slowly getting towards the end of our day's program. But before that, I would like, isn't that a nice picture? I'd like to introduce Dr. Ziyanda Makaba. And the prize for the big picture goes to Dr. Z. She's a senior manager in the provider network relations and contracting space and the James Fund Management Unit at MedScheme. She leads strategy and performance oversight across provider network management, contracting, provider engagement, and managed care risk functions. She's also a pediatric specialist with additional experience in HIV, PMTC, MNCWH, and health system strengthening across public sector and donor-funded programs. And this combination of clinical depth and systems-level exposure underpins a disciplined, outcomes-driven approach to provider network leadership and cost-effective managed care delivery. Welcome, Dr. Ziyanda. The laptop's just buffering.
Thank you.
Thanks.
All right. I'll set myself up. Okay. Good afternoon, everyone. And thank you for the warm welcome. And thanks, everyone, for pushing through. And it's 3 o'clock, and you've been here since the morning. I appreciate it. And although it looked like the room was trimming down, I think this is a good size. So we put this session here because we knew a lot of people will want to stay for this session, right? So we made sure that we push it to the end so everyone can stay long. So thank you for indulging us. All right, so what my session will be on... Oh, is it not there? Oh. Okay. Sorry. Okay, is it now on? Not on? Didn't buffer long enough.
It's not.
There we go.
It's fine. It's coming.
I love it when technology works with you. So what I was trying to say is what my session will be on today is, I think, something that everyone wants to discuss and make sure that we are all aligned when it comes to the managed care processes. So I'll be talking about that, and we'll be covering the 2026 updated, oh, this is not me. Okay, there we go. All right, we'll be covering the 2026 scheme rules and benefit updates that we saw this year. And we'll also be talking about our managed care updates and on processes. And then we'll cover our allied care process. And then we will then close off with our challenges and how we are mitigating those. And obviously, we'll then have a Q&A session later on so we can have more questions and answers so that we can they're aligned. I think earlier on in the presentations we did hear they're having to work together with the scheme providers for the members' benefit, and I think that theme ran all the way through. But an important theme that I think if anyone was to be asked what was the theme of today is how do we work together, us being, from the scheme of managed care with the providers to make sure that with the, increasing cost of healthcare, we still are able to give our members the services that they want, they need to have, and make sure that we are within that service provision. Sorry. All right. So what I'm going to first do is, at a glance in just one slide, what are the 2026 GEMS benefit changes? The biggest one, Tanzanite one, right? We've already had in the previous talks and previous questions, people asking the Tanzanite one benefit changes. So at a glance, we know in hospital, and I want this to settle, it's in hospital, the Tanzanite one benefits are PMB only. Out of hospital, they remain PMB and non-PMB. And then there's been an update or restructuring of the radiology and pathology formularies, and medicine formularies. Then I think this was mentioned also by Ishmael earlier on, that the family practitioner nurse visits are also then limited to 8 consultations per beneficiary per year. And then from the 9th visit onwards, someone will then require a pre-authorization. Then if we have a non-network use of hospital in Tanzanite 1, or also that will have to be a voluntary use of non-network hospital, that will attract a co-payment fee of 15,000 rand. So those are the new updates in 2026 for Tanzanite 1. Then if we look at options that, or changes that affect the options of Tanzanite 1 and burial, we have in the advanced radiology space, 15,000 sublimit per family per year, and that is 1 CT or MRI per beneficiary per year as well, and that affects Tanzanite 1 and burial. Then when it comes to Ruby in this year has now joined the hospital networks, and so also same here, a voluntary use of a non-DSP network will attract a 15,000 rand co-payment. We'll go into what that means as I go on with the slides. And then the other important update is on all the other options except for Tanzanite 1. Non-PMB or elective in-hospital scopes will then attract a co-payment of 1,000 rand if done in hospital. So I think that one will also break it down to say we specifically moving away, and I think one of our first talks was moving away from everything being confined to the hospital space when we've got out-of-hospital options that are available and that are cost-effective, and you'll have the same outcomes in terms of the very important person, the member, will still have the same benefit, but then at least the cost will be less. That applies to all the other options for Tanzanite 1 because obviously it's PMB only in hospital. Then what ties in nicely with the presentation on the hospital at home is that with regards to our whole in lieu of hospital a benefit, that benefit has been extended to include intravenous therapy, right? So that could, that applies to any out-of-hospital setting. It could be in subacute facilities, in out-of-hospital, hospital at home, as and the likes. So that now is an included extended benefit. And if you can see, all of that is to make sure that we optimize care for the member while limiting costs to the scheme. So we always have the member at the forefront of that. Matusi mentioned earlier on that medical circumcision is only covered out of hospital unless it's medically indicated, and those are listed in the family practitioner's guide as to what is clinically indicated. So that is still in line with managing the patients appropriately for that appropriate level of care. And then we come to the last two things that are part of the summary of the benefit changes is wheelchair. We've updated the frequency of how often a member can have a new wheelchair from 24 to 36 months for each beneficiary. And then similar to PAP devices, which includes CPAP, APAP, BiPAP, and VPAP, those will also be at a frequency of 1 device every 36 months, which I'll also cover as to what are the variations in that. Okay, and those 4 updates apply to all our options, all our GEMS medical aid benefit options. So I will now go in each of those updates a little bit more detail so that we can understand the implications for you and your practice and your patients, which are our members. In terms of Tanzanite 1 being PMB only in hospital, what stays the same? Because remember, not everything has changed. Some of the things stay the same. So what stays the same? 1, we still need a request for authorization, which can be sent preferably by UMS. We'll touch upon how best your practices can use UMS to make the process more efficient. It can be sent by email, telephone, yes, especially in emergencies, it can still be done, but we're trying to reduce the call volumes. And then the turnaround time, the standard, or what we're working towards, is making sure that it's within 2 days, 2 working days. And then obviously, if you were doing an auth retrospectively, then that will also have a 1,000 Rand co-payment penalty. And then, so that's what stays the same, and the outcomes of your pre-authorization request will still be sent to the provider, the member, as well as the facility in the hospital situation. What does change is that, we saying it's PMB only in hospital, and the PMB is by standard definition from Council of Medical Schemes, so we're not changing that. And what will become critical and important to make sure a seamless interaction between the provider and the scheme is making sure that we get regular update as managed care organization. So that means that when you have an admission, you will need to give the update so that we are able to manage the level of stay, or length of stay, sorry. And that applies for both medical and surgical admission. And in a situation where the medical updates are now indicating that the condition that the patient has is non-PMB, then the authorization will be declined. So we'll cover everything up to when the investigation was being done, and then after that we will not be able to because of the option benefit that we have designed Tanzanite 1 to be. All right, so just to clarify or to explain a little bit more on the non-voluntary use of designated service of a facility or a use of a DSP. So if there is within 50-kilometer radius of where the patient is, there is no what is the designated service provider hospital, then that will be considered as involuntary use of a DSP. So there's no hospital within 50 kilometers. But if there is, then it will be voluntary use, which means the patient will then be liable for co-payment. So that the distinction is there. And obviously in emergencies and smoothing circumstances, as listed there, that will also then not apply. Right, so that's obviously the theme throughout when I'm talking about voluntary and non-voluntary. Right, so with regards to Tanzanite 1, what then is important, as I said earlier on, the clinical information and updates are required to determine the PMB eligibility. And if those are delayed in sending, then obviously the process will also delay as well. And so then we will send the clinical update, we'll update the length of stay, and obviously if it's a non-PMB, that will be adjudicated as such. And if it's PMB, then obviously we update the level of care and the length of stay accordingly. And once we've got clinical information that shows non-PMB, as I said, then that patient will have to have a decision to make because we will then fund up to diagnosis date. And then beyond that will either be one, the patient will go to state facility where we'll continue the funding, or the patient will then need to manage that at their own cost. Okay. And then with regards to formularies, the formulary prioritizes the fully funded lower cost equivalents. So the high cost items that were previously attracting co-payments have been removed from the Tanzanite formulary. So what then that means is that we're prioritizing those that are more affordable for that option. And I think if you understand, I think the video that plays at the beginning here, if we listen to it, we go through all of our options at GEMS from Tanzanite 1 all the way to Onyx. And Tanzanite 1 is designed for those people that may not actually otherwise be able to afford medical aid. So it's how do we call it, an affordable option for families that might not be able to afford private care. So it won't necessarily be designed to have the the high cost items, but it will still be prioritizing lower cost equivalents. That's the most important thing. All right, so then anything that is outside of that will then not be funded, rather than having to have the member, who's an option that we know is a low-cost option, having to have a co-payment. So it's to protect our members as well as reduce costs. So we don't have members having to pay co-payments for those formularies. So the only thing I can leave you with this slide is it's important to then update yourself as a provider, which are those, or how the Tanzanite 1 formulary looks. All right, so then we go to Path and RAD processes. So out-of-hospital radiology and pathology formularies are now option-specific. So usually, before, we had a Tanzanite 1 and burial, formulary. Now, Tanzanite 1 is separate and burial is also separate. So we've got 2 separate formularies for those, it's no longer one. So it's important for you to take note of that if you were using them combined last year. And then, so these formularies are applicable to out-of-hospital events, and then they'll obviously be paid from the allocated pool of out-of-hospital events, and they will be aligned to a PMB treatment plan when they, if we're talking about in hospital. And the tariff codes, the PMB care plan rules apply for the tariff codes, and that means that if it's an APMB condition, it will be covered as a PMB level of care. And if it is not, then obviously it will then be rejected in that case. So then there will obviously be a rejection code that will explain why that item is being rejected. All right. Then if we go to advanced radiology, we'll be looking at both Tanzanite 1 and burial. So starting with Tanzanite 1, for Tanzanite 1, we'll go to in-hospital benefits. So for in-hospital benefits, remember Tanzanite 1 in-hospital is PMB only. So that's important, so that we need to make sure that we confirm that the diagnosis is PMB eligible to approve the request. And then the scan will not be approved if it's obviously a non-PMB condition. And then out of hospital for Tanzanite 1 is similar to burial, whether you are in hospital or out of hospital, because out of hospital Tanzanite 1 covers both PMB and non-PMB conditions, and a burial is the same in and out of hospital. Right. So what's important to remember is the first scan. If it's a first scan and there's sufficient benefits available for that member, then obviously that will be approved, and obviously the approval is also subject to available limits and managed care protocols, right? And if there's insufficient benefit and the scan is PMB with a PMB level of care, then it will also be approved because it's a PMB condition. And then if there's insufficient benefit and the scan is non-PMB, it's important to know that then, or is not a PMB level of care, then we have to decline the request in that condition, in that situation, sorry. And then obviously second scans or more will obviously depend on the underlying condition, because they're not necessarily automatically covered, and the request will be declined when there's no longer any sufficient benefits for that. Also, at the corner there, just wanted to show what we're talking about when we talk about advanced radiology. All right, then a big change in terms of the family practitioner and the nurse practitioner consultation is that there's a new threshold. And for the first 8 visits, you wouldn't need a pre-authorization, but from the 9th visit onwards, they will need a pre-authorization for us to be then able to cover their funding for those visits. So the member and provider, obviously, before the consultation, should confirm the number of visits that they have, and then from the 9th visit onwards, they will then need a pre-authorization that will be released and must be used within 5 days. It's for 1 visit, but it got 5 days before it can no longer use it. And then obviously the claim will be paid if an existing auth is there. If there's no existing auth, it will pend for 10 days. And then after 10 days, then we will not be able to cover that, so that will be rejected. So if there's no auth request after 10 days of this request, then will be, of the claim, sorry, then we will not be able to cover that claim. And I think in situations where you're not able to, I think the last part of my slide over there, don't know where my pointer is, sorry. Yeah, so the last part here, that if, it's after hours or it's on weekends, public holidays, we can then request the auth retrospectively, because obviously at that time the call center is not available for you to get the authorizations. All right, then we'll go to the rest of the benefit changes, starting with the Ruby being hospital network. I think as long as you understand the premise of hospital networks, the only difference with Ruby is that now it wasn't a hospital network option before, and now it is. So then it is managed similar to all other hospital networks. That if a patient uses a non-DSP hospital, and there is within 50-kilometer radius another hospital, then it will attract 15,000 rand. But if it's emergency and there's no network hospital around within 50-kilometer radius, the co-payment will not be applied. And then when it comes to the elective G-scopes, the explanation for this, I think, is in the theme of the day of making sure we're moving out of using hospitals, I mentioned earlier on, to using, whether it's in rooms, whether it's in day theaters, to make sure that we're reducing the cost and still making sure that we're doing the necessary investigations to make sure that our patients get the appropriate diagnosis and treatment that they'll need. All right, and then, it's just talking about which scopes we're talking about. So it's all the gastroscopy or colonoscopies or sigmoidoscopies and any upper or lower GI scope. Right, then wheelchair, I think this one was covered sufficiently in the overall. There's not really any additional new things with that, except for that it's available every 36 months for a new wheelchair for a recipient. And obviously that is applied through the normal process. So there's nothing that has changed in terms of the process, but the duration between the request of a new device or new wheelchair. When it comes to in lieu of hospitalization, this has been it's part of our alternative to hospitalization. Now it includes the IV therapy, and if this is limited to subacute hospitals, physical rehab, private nursing facilities, hospices, doctors' rooms, as well as hospital at home, with what we heard earlier on in our presentation. And these will also still need a pre-authorization, and this is all to make sure that, as our earlier talk, we reduce unnecessary admissions where treatment can be easily given out of hospital. So now people are able then to get authorization and claim accordingly for our members. We've covered the circumcision. I think it was also covered in my preceding talk, so there's not really much addition there. And then with regards to PEP devices, there's one important addition. So yes, as much as the actual device itself is released or authorized or funded, that's the word I'm looking for, funded every 36 months, the actual consumables that come with it will still be funded on a need basis on year 1 or year 2 and year 3. So year 1, for example, you request a PEP device, you will receive a PEP device with the consumable. Year 2 and 3, depending on the need from there, they will be covered differently. But the actual PEP device will not be covered until the 36-month cycle is complete. I hope that's clear. Right? And this is applied to all our options, not limited to some. All right, so now I wanted to just go into the process or the managed care processes surrounding allied health providers. So what I wanted to start with first was the actual process in terms of how we should be looking at requesting doing our pre-authorization requests. So what we do find is gaps is, yes, the process has, I think, with our call center volumes and all of that, which I'm going to touch upon, but there's also sometimes when the information is being requested, we don't get sufficient information, and then the auth will carry on pending until we've got sufficient clinical information. So the information that is required as a must is the member details, provider or practice details, the claim information, and we need it in the treating provider's letterhead with the treating provider's signature. And then we also, it can also be acceptable to have the treating doctor's note stating the clinical reason for the referral of that particular patient that is being treated by that doctor to the allied care that is requesting the authorization. in situations where it's mental health, the DSM-4 form is with a doctor's clinical motivation, stating the clinical reasons why the allied care professional needs to see our member is sufficient. So those are critical. So sometimes when I've submitted a referral, but it's a referral. Let's say I'm an allied healthcare professional, and I'm referring somebody in my clinical stationery. That does not apply as a referral from a doctor, because I'm referring to myself. So we need a referral from a doctor to you saying that you need to see this patient for X, Y, Z. And I think if it works like that even during my training, right? So I wouldn't, let's say I've got a child who's got CP and I need a physiotherapist. The physiotherapist doesn't just walk into my ward and start giving physiotherapy in a child admitted for a chest infection because they are CP and they don't have a good cough reflex. And now they're doing physiotherapy, but maybe it's not necessary at that time. So it has to be the treating provider has requested the service, and then we are requesting for an authorization for that. What is not valid as a referral is using a sticker alone to say, okay, here's the patient, here's a sticker in a referral note without anything else, is using, like I mentioned, your own, as an allied health worker, your own referral note. Because some people say, yes, it's my own referral note, but it's a doctor who signed, and there's a doctor's stamp. I don't know if it's the doctor who signed or it's the doctor's stamp, so we need a verifiable source. Then obviously, once you have those, you submit them to one of those email addresses. I'll explain which one you use when. And then obviously the authorization process then starts. The visit dates are captured. So if it's retrospective and you've already seen, we'll capture the visit date and approve accordingly. If it's a prospective, then obviously even the default visit will be given, and then as clinically indicated. And then in a situation where the healthcare worker needs more than the default visit that are provided, then you would need to then submit a letter of motivation. And this obviously will then say, okay, I need to see more than the default visit because of X, Y, Z, to state why you need to see, or why we need to extend the length of stay or the visits for the patient. And once all this is done, this is for the authorization process. And then obviously then you still need to submit a claim once the authorization has been approved. So just to simplify what we meant by those two email addresses, or what we mean by prospective or retrospective that you may have had. So a prospective process is when you have not seen the patient yet, you're still going to see. And as an allied worker, if there's a patient who's admitted, you will need to send a separate authorization request for that, and then you get an approval on the length of stay. And then if you need more visits, you will still need to have a treatment plan and a letter of motivation, as I said, and then obviously then those are reviewed and adjudicated accordingly. Then in that situation, you send it to hospitalauth@gems.gov.za. And for the retrospective, a patient who has seen, and now you're doing a pre-auth or authorization request, because it won't be pre, you will send it to inquiries. But the situation is similar, that you will need a separate authorization, and you will then have only default visits allocated, and then if anything additional, you will need to then send through. And that table on the side there is just showing what we mean by allied healthcare professional that are affected by this that are included in this process. All right. So we've had, I think, starting from the beginning of this year with the benefit changes, an influx in our pre-authorization call center. And as a result, we've had a bit of a backlog, a bit of challenges with that. So I think some of them were linked to the 2026 benefit updates, especially with the Tanzanite 1 changes. And as a result, both from members, from providers and from facilities, we've had an influx of calls in our pre-auth center, and then that has obviously affected the turnaround time and the processing of the authorization requests. So what we have been requesting from providers, we have other platforms to get through to our authorization center or to get pre-authorization. So maybe what we're saying is in situations where it's an initial request, we can then use the electronic platforms. And in escalation, there's also escalation platforms that I will be sharing, and only call in those areas where it's emergencies and you know, an immediate response is needed. One of those, as I've got here, is UMS. You would have seen in our first table, as you walk in the main entrance, we've got our flyers there for UMS. It explains to you what UMS is and how we can offer training. I'll also cover it a little bit here, but it's something that we can do. We can use this utilization management system. We can use this to make the process a little bit more efficient, and only escalate those telephonically that need immediate and urgent attention. What we're doing to address the challenges as a managed care organization is some of our agents are working extended or overtime, and we're focusing on reducing the backlog and prioritizing, I think, the electronic submitted requests, so that we don't have those providers also calling in, as well as the oldest requests are also being prioritized, and any urgent or PMB or clinically sensitive cases are also prioritized. And we're doing some manual verification on a daily basis to check where we are, how do we need to deploy our agents and optimize our workflow. So as I just touched upon the UMS, if you leave with anything from my talk today, I wish to just say, like, for your practice, if you have a practice, for yourself as a practitioner, if you're solo, you're just doing it for yourself, either from your practice, get your practice manager, or whoever is managing your practice or admin to be able to get UMS. So what it is it's a secure online platform where you can create, update, and get and like track how far you are with regards to the pre-authorization request for GEMS. And you do that electronically. What it does is that it will then generate a reference number, and then you'll be able to check your pre-authorization once it's approved. So you'll be able to check it there. So you don't have to call and check, is it approved, is it approved? It will show what status it's under on the system. So you'll be able to upload all your requests, upload all your referrals, any letter of motivation that are needed. You're able to upload it there and track it real time instead of sending an email, calling, and doing multiple things. So it reduces that administrative burden as well. And obviously it reduces the call center volumes and the backlog. You'll be able to see when it's approved, when it's pending, or when it's declined, and it will tell you why it's pending, what is needed. Usually when it's pending, there's clinical information that is required, or other adjudication processes are still underway, or if it's rejected, it will tell you exactly what is it about the scheme or managed care criteria is an issue. And then all correspondence are sent to the provider, as well as the outcomes as well. So how do you get this? You just send an email to that email address, and you get then contacted, sent a form, you fill that in, and then you then get training support so that you can access the system. When you have technical problems, there's also a way to get technical assistance. You send an email there, or if it's urgent, you could call that number, but that's only available during working hours that are listed there. But I think we even have a flyer that you can take with you. I think we need a QR code. It's another theme for today. We need a QR code. So we'll have, I think I've already thought of 2 QR codes that we need. I'll tell you the next one. So we need a QR code for the UMS as well. I think someone mentioned earlier about the escalation matrix, right? It's important, I think, for us to share that escalating electronically does at least give you that track, that I've sent this at this point, at this time, and then I need to follow up at this time if it's not been responded to. So if you use UMS, you would start from step 2 of this escalation process, because this is almost equivalent as using UMS, but just a little bit more efficient UMS. So obviously you would escalate it if you're done email, or any other way, you will start with the step 1. But any electronic submission from UMS, you'll start from step 2, and then you'd escalate accordingly. So this, I think, is important for any provider to have, so that you know the appropriate channels to escalate your issues so that they can be resolved. Sometimes sending it to one person depends on that one person to answer your question when they're available or when they're not busy. But sending it to a multi-manned email, if I can put it like that, then that work is usually divided and, and conquer, and you get responses quicker. All right, then medical advisory. There was someone who asked, and I think Itu answered, about how to access medical advisory. Besides having a phone, picking up a telephone call, we can use a link to request medical advisory support. And this one is not going to be for if you've got a query with your claims, or your auth is not being approved. No, it's when there's a clinical discussion to be held between a provider and the medical advisor. Maybe the clinical funding decisions you don't understand and you need more explanation, you need more discussion to give context, you would be able to do this. This is the second one we need a QR code for, because it's there's the link that you can use. You click on that. When you click on that, you will see this landing page that says book an appointment, and then obviously you will be able to select if you want to HEM is hospital advanced management, CMM is chronic medicine, and then oncology, if it's any of those. Usually most will be hospital advanced, but it's not limited to that. And then you would select GEMS as a scheme, you select the time and appointment that you are available, obviously that shows is available on the platform, and then you complete your details, the patient's details, so that when the person calls you back, they've already got that information, because you wouldn't be calling about someone who hasn't got an auth yet, and someone has an auth, and the clinical process is what you want to query. Then you would give all that information. So then the person calls back, it's a peer-to-peer interaction, you explaining what the issue is, and they explaining why the clinical funding decision was as such, or what is happening with the process. So you can do it in that way, or there's an email inquiry that you can use as well. All right, that brings me to the end of my presentation. Just in summary, the thing that we touched upon was the Tanzanite 1 changes. Big change in hospital, PMB only, but otherwise out of hospital remains PMB and non-PMB. And there's primary healthcare visit threshold has been limited to 8. On the 9th, you will need a pre-auth. And then the allied healthcare process will need to obviously submit a valid referral. Then you get your default days, and then obviously that if longer is needed, letter of motivation is needed. And then there's been an update in our formularies, acute formularies, as well as our RAD and PATH, that also you need to familiarize with. And then for the 2026 changes that affect Ruby being a hospital network, the co-payment with the scopes, wheelchairs and PAP devices being 36 months, as well as circumcision being over, in hospital, unless clinically indicated, and IV therapy included in lieu of hospitalization. Then we also covered our support, and I think where I want to leave you with that is using UMS and making sure we use the appropriate escalation systems will alleviate some of your frustrations. Thank you so much for your time. I adjourn. Thank you.
Thank you very much, Dr. Ziyanda. Maybe just a little change in schedule. I know you all are sitting here very tired. If this was a fitness app, you'd all have a badge by now. But I think just based on Dr. Ziyanda's talk so far, I think we're just going to forge ahead into our Q&A, because I think there's going to be a lot of questions off the floor. So I'm going to hand over to Lesego Nong, who's going to facilitate this question. He's not going to be as good as me, but he'll try. But thank you very much. Dr. Z will stand here as well. Thank you very much, everyone.
No, good afternoon, everyone. I would like to start by thanking Mel for taking us throughout this day. And like she said, I won't be as good as she was, but thank you very much. I'll try my best, because we've seen at the time is not on our side, and everyone is quite anxious to ask a lot of questions based on what Dr. Ziyanda has presented. As Mel has already introduced me, my name is Lesego Nong. I'm a provider license office manager at GEMS. As you can see, we've got the other service provider network team joining us in front. We will actually be taking questions across all different SPNs that we normally refer to. That means even if you don't have question for Dr. Ziyanda, the other SPNs from Azosa,